Today I'm going to be talking about some of our computational approaches to the understanding of the public health problems, in particular the US drug overdose epidemic. I do have a conflict of interest statement here that I'm although I'm a full-time faculty member at the University of Pittsburgh, I'm also president and co-founder of Epistemics, a for-profit startup company that produces and distributes software. And later in this lecture, I'll refer to some of the work that is similar to what we're doing at Epistemics. The main objectives of my lecture today are going to be to show computational approaches that can lead to better understanding of the drug overdose epidemic, including the epidemiology, the age structure, and forecasting. And the objective here is for you all who are computational scientists to show you how we use computation in these complicated and important public health problems. A few years ago, I was invited to write an editorial for Science. Jeremy Burke was the editor, a friend of mine, and there was a special issue on pain. And I decided to write it about forecasting the opioid epidemic because I was impressed we had a major epidemic and there was little or no computational work going on in trying to understand the epidemic. And so he gave me this opportunity. And I wrote about the epidemic as being a complex, dynamic process that should be approached as such, and that we needed a coordinated national opioid epidemic modeling program. This was 4.5 years ago. And at that point, I started to get involved myself and my team to do this kind of work. It wasn't too long before we had our first major paper that was published in Science, entitled Changing Dynamics of the Drug Overdose Epidemic in the United States. And it was surprising to me how we, in short order, went from really not working on this problem to having a paper in Science that is now in the top 1/10,000th or 2/10,000ths of all papers in terms of its recognition by Altimetric. So we can make an impact simply by applying some pretty straightforward techniques that simply just hadn't been done before. And the major message of our paper was that that we just took all of the available data on the more than 500,000 deaths and put them all into an analytic system, this is just a simple graph of the mortality rate of drug overdoses from all drugs in the United States from 1979 through 2016, the available data at the time. The real data are the circles and the solid line. The fitted curve, which is an exponential curve, is the dashed line. And what we were able to show is that the epidemic for almost 40 years had been growing on an amazingly exponential growth process. And also, surprisingly, nobody had noticed this before. Okay, trying to get it to go forward. That if we looked at the individual drugs that go into that smooth exponential curve, there was heroin and prescription opioids and methadone and cocaine, other narcotics, methamphetamine, all of the drugs that you hear about in the news, and they were going up and coming down. And yet somehow, even though there was no smooth pattern by individual drugs, when put together, drug overdoses were an overall smooth process. So we got interested in looking at this in more detail. One of the first ways we did it was to look to say, well, what ages are the drug overdoses by year? So we drew a heat map. On this heat map, we have on the x-axis is the year in which the drug overdose death occurred, and on the y-axis is the age. And what you'll see is the heat map, the color will be the rate of deaths in that particular age per year. When you do that, this is the kind of pattern you see that earlier on in 1999 on the far left, that the epidemic had most of the deaths were in age 40 to 50. And as time went by, the upper edge of the epidemic kept getting older, and the epidemic intensified. And every year there were more and more. And at the same time, the epidemic was broadening. So this is a snapshot, a way of looking at the age patterns of the epidemic. A pretty simple way of looking at it, and but it's striking. There are some pretty sharp boundaries there. One boundary here, and I'll come back to that, along the top, and the other one along here at about age 18, where kids below age 18, for the most part, don't drug overdose. So then what you can do is you can say, well, if that's the rate of overdoses by in the total, what about for individual types of drug overdoses by the total, or male or female, male or black or white, or other ways of cutting the data, and also by individual drugs. And so you can, this is now not only a snapshot of the epidemic, this in the upper left here is where the first graph I showed you, but now we're slicing this. So let's look at some of these here. Like here you can see the cocaine epidemic among blacks look very different than the cocaine epidemic among whites. The epidemic of prescription drugs is pretty strong among females compared to the heroin epidemic. And there are a lot of sub patterns that are, you can see just with a simple computational approaches to looking at these data. There's the overall data comparing males and female. You can see there's a big difference in that the females don't have the younger age sub pattern. The black versus white, again, the black population has less of the sub pattern. And then there are variations by individual drugs as well. So this is it's a complicated epidemic, and this is a simple way of looking at everything together. Another way of looking at the data is by where the overdose deaths are by drug. So by map, here are some hotspots for overdose deaths across the United States, with the prescription opioids shown in the upper left. Heroin has a somewhat different distribution. Fentanyl in the upper right. Cocaine is mostly a large city disease. There are a lot of dots there that are the major cities. And then methamphetamine is a Southwest disease. So again, that there are a lot of heterogeneities in the epidemiology of drug overdose deaths. So then we can pause here for a second and just say, well, now we've seen that the overall epidemic is been growing along this remarkably smooth exponential trajectory. But paradoxically, the overall epidemic is composed of multiple sub-epidemics with a lot of heterogeneity and without obvious structure. And so that invites us to say, well, let's look at those. If there's more detail that we can tease out of that. The epidemic is increasing and decreasing, but staying on this this exponential trajectory. At the State of the Union, in his last State of the Union, President Trump said that drug overdose deaths declined for the first time in nearly 30 years, and we will not quit until we have beaten the opioid epidemic once and for all. So we were, at the same time that this address was being given, we were analyzing some of the minor rises and falls in the overall curve. And we wrote another paper, this one on the role of one particular form of carfentanil, sometimes called the elephant tranquilizer, that is 10,000 times more potent than morphine. And it was making its way into the United States and causing a lot of overdose deaths. And in fact, when we looked at this, we found that the drop that the president referred to was in fact an artifact of a rise and fall. And we got obviously some press out of this. People were interested. And here's the curve. Remember, this is just the same curve that we showed in our science paper with this 40-year exponential shown in red now. But what had happened was from these few years, there was this hyper exponential rate of growth. And then there was a drop, but precipitously. And now we were back on the long-term exponential trajectory again. So even though there was a wobble, the improvement really, all it did was put us back on the expected curve after a unexpected hyper exponential acceleration. And when we looked at this in detail, that there were several states where the carfentanil had made it into the drug supplies, and particularly Ohio, Pennsylvania, Florida, Kentucky, and Michigan. And those states all had this bump, this sharp spike in deaths, and then an equally sharp spike when the carfentanil disappeared, when China started to regulate carfentanil and imports into the United States decreased. So, and the rest of the country, shown in dark, the black line, was continued to grow along the exponential expected trajectory, except for these places. So, even though there was a minor exception, it was just that, a minor exception. So we looked even further into this question of the age and of who has drug overdoses and how that may change by when they were born. And we had another paper last year in Nature Medicine, this time looking at the generational patterns as well as the age. So not only how old you are when you're using drugs, but what year were you born is an important determinant of your susceptibility to having a drug overdose. Well, here are the same curves that are the heat maps that I showed you earlier, which are by year on the x-axis and by age year, and this line going up as the upper boundary of the age, and this age boundary here being the lower boundary at age 18 for males and females and the like. And one of the things you can do is you can just turn these data a little on their side. And instead of having age now on this axis, you have the year of birth on the y-axis. Still have the calendar year on the x-axis, and so you get a slightly different, exactly the same figures, but now you get a slightly different look at the data, and that has some implications for generations. Now we're analyzing data looking at year of birth rather than by age. And so if this is the curve of birth year versus calendar year, and then you can slice this representation into the generations from the so-called silent generation born before 1946, the baby boomers from 46 to 63, Generation X, millennials, and Generation Y. And interesting that the people in the silent generation just didn't have drug overdoses. And it was the baby boomers who were born in 46 who started the drug overdose epidemic. There was a pretty sharp boundary there. And then other age generations, you can see there's a bit of a dip in between this peak and this peak around the time of Generation X. So the patterns are changing according to the generations. Another way of looking at these data, and we'll look at it in more detail here, is that you can, on the x-axis is the age at which a person dies. The y-axis is how many deaths there are in that for that age. And each curve is a increasing in the birth cohort. So people born in 72, 3, 4, 75, 76, 77. So every year that people every birth cohort, the rate at which they die from drug overdoses increases, and it does so dramatically. So there's something that is propagating within the society toward younger and younger ages toward the drug use and drug overdose deaths. If you look at that as a function of how fast the overdose deaths, the doubling time is by birth year, that the doubling time used to be if you were born in before the epidemics really started in 1946, the boomers. The doubling time of the epidemic was measured in decades, whereas now people who were born in the 1990s, the doubling time for how fast they reach an increase in drug overdose deaths is going up with a doubling time of about 3 or 4 years. So dramatic change by generations over time. You can plot these same curves that I showed you that were a family of growing curves. Here, this is the same sets of curves now, but all displayed on a single figure. Age is here, mortality rate here, and the year at which they were born is shown here. So that old people born in 1950 really didn't have that much even into their 60s. But as birth cohorts increased, the rate at which people died from drug overdoses increased dramatically. That's the number of deaths per year. This is the death rate cumulative for those people who are by cohort, by age. And these data are amazing in that they are so smooth and regular, almost perfectly regular. And these are, all we did was just take the raw data and essentially plot it by cohort, and you end up with this dramatic change over time. And that, so you can see the differences here. One of the things we noticed is that there's a family of curves here, and you could fit these curves mathematically to a pretty good first order approximation. Show that the birth cohort 1950, 60, 70, 80, 90, that as a function of age, and another way of expressing this is that all of these fit onto Gaussian curves that where the curves are continually shifting to the left and increasing in amplitude. The data is incomplete for this curve here, but this is if you fit it, this is what you expect for that birth cohort from the birth cohort of 1990. And for the other birth cohorts. What ways to measure these data are that if this is the amplitude, how high the peak is for that particular birth cohort, then this is the age of the peak. So that people who were born in the 1960, the median age at which they died from drug overdoses was in their 60s, and they died at a rate of 30 per 100,000. Whereas both the peaks and the ages change over time, and you can graph those things as a measure of what's going on in the epidemic. That by birth year is that that if you were born in the 40s, your peak age of drug overdose was 60 or so, and then it's declined now, keeps getting shorter and shorter. And the rate at which the amplitude has been increasing as well. And if you plot those two against each other, the peak age on the x-axis and the amplitude on the y-axis, and do it by just plot them by year, by birth cohort year here, and continuing along all the birth cohorts, you get this interesting curve that goes up to the left and then up again. So something happened here in this transition. There's sort of a two-component pattern to the birth cohort distribution of drug overdoses. You can look at this in a slightly different way. Here we have a plot, a three-dimensional plot where the mortality rate is on the upward axis here, and on the x and y axis now we have the calendar year and the birth year. And and this shows the 3D plot of that. I'm going to stop it. Stop it again. So that you can see that there is a distribution. There's this little valley between that we see before. And there's this ridge here in the more recent years. So that we have to explain this topography of the epidemiology. And so that's our next challenge. Now that we've seen that there are these generational components that are the ridges here, and now we've got this other cross-cutting ridge that is in the more recent years. So this visualization, taking these data from epidemiology and trying to sort out what are the components, starts to give some insights. So having worked with these data for a while, and knowing that the age and the year and the birth cohort mattered, we realized that there are other better ways of looking at the data. These and sometimes these are called age, period, and cohort, or APC data. And so we decided to come up with a system with, instead of the usual 90-degree coordinates, to have hexagonal coordinates on heat maps. And we published this in Epidemiology last year. And I'll walk you through this a little bit. It's a nifty way of visualizing data by year, by birth cohort, and by age. And this is just, the reason this works is that a person's age is, of course, the calendar year, whatever calendar year is now, minus their birth year. So these are all related to each other. And the calendar year is sometimes called the period. And that's important because things happen at a given period, like the Vietnam War. Another is age, and of course, events characteristically occur at life stages like teenage. And then the other one is birth cohort, and that's so that there are shared life experiences, societal effects that stick with people that were born and raised and went through their formative years together. And so teasing out age, period, and cohort effects are an important objective, and being able to see these in displays is useful. So as I said, is that if you map something, if you graph it, if you have the birth year on this axis, at hexagonal axis, and the calendar year on this axis, then by definition, the age is going to be on this axis. And so you can take these same plots that we had before and replot them as we refer to them as hexamaps. So that for this, now we look across here, we see that the birth cohort 1950 is the boundary for when the epidemics began. That this line here now is the age, and this is age about 20 or thereabout, 18, 19, 20. And that as time goes by, that the epidemic is affecting different people in different age categories, if you look at it coming across this way. So it's just a nice way of looking at these age period cohort effects. So I want each time I talk about this, it's people always get confused. So I tell people that hey, this is here's an easy way to understand. This is how you're supposed to look at them. Just tilt your head a little bit back and forth, and you'll get the idea of looking at whether you're looking along which cohort axis you're looking at, which axis you're looking at, the cohort, age, or year. And if you then do that, you can take those same plots that we had before, and now you can see that that this is the upper boundary of the birth cohort. This is the boundary of the age, and that this is the calendar year, and that something is, for instance, here is this is that ridge that we saw in the three-dimensional plots going up sharply. That's due to the fentanyl type drugs. You can use the same plotting methodology for lots of other causes of death too. The top line shows the overdoses for males, all, and for males and for females. You can do the same thing for prostate cancer deaths. And if you see prostate cancer, compare that to the overdose deaths, you see that essentially older people older than age 60 have been dying from prostate cancer for as long as we've been tracking the data, a very different pattern than the overdose pattern. And on females, they're obviously not dying of prostate cancer. Similarly, with breast cancer, you can plot that. And then the nice thing about visualizing this is that you can see that the death rate, the median age of deaths has been increasing. There's no substantial birth cohort effect. But with time, the age has been increasing. Motor vehicles pattern is fascinating, worth a deep study by itself. You can see that the males have much more than females, and there are these very prominent upward and downward striations on the patterns by year, and those reflect things like when there was a gas shortage, the 1973 gas shortage shows up, and over time the deaths have been declining. Most of the deaths are either younger males or very older males. So again, these are I think these are very nice snapshots of looking at mortality. We're talking about drug overdoses here, but it can be used for anything. So now we decided, since we had these these hexagon heat maps, we thought that maybe there are other ways to use it too. So we changed the pixel sizes. We set the hexagon pixel size proportional to the rate, and use the color to convey other information about that pixel, like the male to female ratio or the like. And we'll look at some of these. And they allow you to look at the epidemic computationally. Again, I hope the point here is that we're taking computational methods to understand the epidemiology and apply new ways to look at data through computation that I think make the data a lot easier to look at and understand. So here's a nice graph of the drug overdoses. This one shows the male to female ratio. The redder it is, the more males there are. The bluer it is, the more females there are. And when it's mixed, it's mixed. Here is this, and the size of the pixel is proportional to the death rate here. So in there you have these teeny little pixels here. There's very low death rates, and here's where, remember, here's that 1946 boundary for the birth cohort. Early, up until about the year 2000, almost all the deaths were strongly male, and that the ratio then changed. This is still more male, but the ratio now is only here now 2 to 1. And this is in the age categories of ages 60, 50. So these are a lot of female drug overdoses in the recent past in this particular subset. And then and then as the epidemic moved on, this sex ratio has started to reverse again. But it's a nice snapshot of the sex ratio over the last 30 or 40 years and over the last 80 years of birth cohorts. You can do this this is when we looked at for male-female ratios. You can do this for white-black ratios, where white is in red and black is in blue. The epidemic tended to be in black urban settings in the United States. As time went on, it was more and more white, but particularly in young whites. And then the same thing is in the urban-rural, as you see transition. So you can visualize these major transitions in the epidemiology. So these are the changes from the last 40 years or so, changing from male to female, white to black to white, urban to rural, but with some nuance in there. Well, the next thing to ask was, well, can we use the methods to look at changes in drug use patterns? We looked at the changes in the demography. So all we did was a really simple method. We just said, for any given combination for any given pixel, any given combination of age and year and birth cohort, what were the deaths due to in that particular pixel? So that if one pixel might have high cocaine and high methadone, but low methamphetamine and low fentanyl, whereas other pixels might have other combinations. So by doing k-means clusterings, you can say which pixels are most like each other in their drug overdose death patterns. And we just put a boundary around on our Hexamaps starting in 1999, because that's when the data started to be reported by drug. Before that, the drugs, it wasn't reported by individual drug category. And we also drew a boundary around it at the 1948 cohort, because that's when the epidemic started, and at the lower boundary at 15 years old. And so we said, within that grouping, are there pixels that are more like each other with regard to their drug death patterns? Are there pixels that are more heroin and less methamphetamine? And if so, how do they relate to it? And then we just clustered the pixels and said, if we say there are 2 groupings or 3 groupings or 4 groupings, so you can cluster them, and most of the clusters are by year. The drugs changed over years, but as you keep chopping the clusters by drug patterns, you start to see that there's another boundary here, which goes this direction by cohort as well. So that there are boundaries that are up and down, and there are boundaries that are cohort by drug. And so this means that younger people in the recent couple of years have had different drug usage patterns than older people have. And notice again that these maps of drug overdose death patterns were based entirely on the drugs, and yet the colors they tended to cluster with each other in very nice spatial segregations. It's possible these could have, all the colors could have been random, but they're not. They're tightly clustered. And I won't go into it, but other than to say this purple color is mostly prescription drugs, a lot unspecified drugs, and not much else. Whereas this color down here, the young people, is mostly heroin, and this color here is a mixture of heroin and prescription drugs. And then this particular pattern up here is methamphetamine is becoming a major pattern. So you can use the agent to break out who by age and birth cohort who's dying from what drugs. and I won't go through that other than so that there was this birth cohort difference around 1975, and that's when the epidemic, showed the birth cohort showed us somewhat of a slowing of that, but it also was a bifurcation in the drug pattern. So something is different about older drug users versus younger drug users. So let me take a step back here for those of you who don't think about drug overdoses and say, how did all the opioid epidemic happen? There's a paradox, and that remember that we have this smooth and predictable epidemic curve, and yet something is holding all of these epidemics together, older and younger, different drugs, different birth cohorts. And yet when you put them all together, you end up with a smooth exponential process. Well, here I am speaking to a group of computer scientists, and when you talk about an exponential growth pattern that has been defies explanation, or at least as far as I understand it, defies explanation. Maybe in the Q&A, somebody can tell me, explain to me why Moore's law should hold and whether it still is or not. But it's sort of the same thing, is that there's deep processes here, hidden hands at work that we need to understand. The chronology to explain it is that there was an advocacy for increased treatment of chronic pain. New higher dose formulations of opioids were used. People who became addicted, that heroin was cheaper than the drugs themselves, and so people switched over to heroin. And then fentanyl is a synthetic drug instead of a agricultural product, was cheaper and easier to manufacture and transport. And those are the sort of the immediate causes at the top of the tree, but there are root causes at the bottom, and those were issues like the lower drug prices there are these important societal, the loss of sense of purpose and the despair, and the communities that are most hit by these are that there's the loss of sense of well-being, loss of sense of purpose that is a major puller that we need to understand. So we also have gotten a little into forecasting, not much. My colleague Hare Jalal has done some taking these data and training some neural nets based on the historical data by AgentBased and Cohort, and then recomposing those and projecting them forward. And so we have some, what we think are some reasonable forecasts, and the forecasts say we're going to, for the most part, stay on the exponential growth trajectory, and that the birth cohort and age patterns will continue to shift in the same directions they've been shifting. We've also done some agent-based modeling. I mentioned that I work a lot on agent-based modeling. That's what our company Epistemics does. But we've done some work through the university, funded by the CDC, to develop some agent-based models of the drug overdose epidemic. And we have a web page that, if you're interested, we have a simulator called FRED, the Framework for Reconstruction of Epidemiological Dynamics. That's a large-scale agent-based simulator where every person in the United States is represented there. You and I are in there. It's just that our demographic characteristics are slightly altered so that we can't truly identify any given agent with a given person. But there is a Don Burke-like person who lives not too far from where I live, who has about the same age that I do in our simulation. So with that, we then took the natural history of people transitioning from prescription drug to use of illicit prescription drugs, to injecting heroines, to having an overdose, and and built some agent-based simulations about that. And I think let's see if I can, so basically Fred is this, as I say, it's a large-scale agent-based simulator with, we have, on the far left, we define conditions and states, and it's a state transition process. We have a special language that we call Fred that, as well, that we code up our simulations. And we're now in the process of turning this into software that can be used by anybody, either at a desktop or through the cloud. And those products should be out pretty soon. Let's see if I can do this. I'll see if I can. I'm going to stop share, and I'm going to reshare. And so here's the Fred web. Let's choose, I'll choose the easy one, Pennsylvania. And let's choose my county, which is Allegheny County, Pittsburgh. And then we have some agent simulation. This is the Pittsburgh area. The dots are individual who are users. The red are going to be overdoses. And let's compare treatment with the existing amount of naloxone, but let's double the amount of naloxone, and let's double the amount of treatment sites, and then we'll run the simulations and compare the outputs of the two different, and the number of drug overdoses and overdose deaths that we get. So we do this. We've done that for many of the counties of the U.S. to give decision makers some help and saying, if I increase my naloxone for prevention, for reviving people from drug overdoses, or provide treatment slots, what can I expect in terms of death? Fact is that doubling these things makes an impact, but not a very much of an impact, because we need a lot more than we're currently using. Doubling is not enough. So let me go back now to my presentation. Yeah, I'm a little past there, I think. And that's where I think I want to be. And so let me conclude my talk now. I hope I've given you some illustrations that the drug overdose epidemic has been following a smooth and predictable course for 4 decades, but that there are these subpatterns that are discoverable, that by doing the right type of analytics, they're not easy to see, but with the right way of combining the computation and visualization. The age structure is particularly important, with this idea that the epidemic started with the boomers, that there was a bifurcation with the younger folks, and that the forecasts are that we're in for this exponential growth for some time. But it's raised some new questions about how can it possibly be that we're held on to this exponential trajectory, and that what accounts for these generational effects, and why the boomers, and why the bifurcation, and what can we say about the socioeconomic drivers and behavioral dynamics? And that's the next thing we're going to start working on, is comparing the issues of sense of well-being or income or other metrics of social cohesion as predictors of overdose deaths. And And are we going about this the right way? And I think the answer is no, we're still not going about it the right way. We've got an exponential growth process that we haven't made a dent in. So we need to do something differently. So my message to you all here is that through the use of computational analytics and modeling and visualization, we can gain understanding into these deeper social, economic, and behavioral drivers of the epidemic. That these increased understandings of the deeper drivers should lead to sustainable reductions in substance use disorders and overdose deaths. And I want to thank my colleagues on all this work, and particularly Hare Jalal, who is my closest collaborator in all this. Hare is a physician computational genius, and I really enjoy working with Hare and the rest of the team. So, and with that, and thank you for your attention. Those are, for those of you who are interested, those are poppies. So.
Thank you so much, Don. That was an absolutely terrific presentation. Got a few questions that came up in the chat. And the first is from Sorrel Schwartz, and he had a comment about that he said it would be interesting to compare this cohort data with tobacco-related disease and death. I don't know if you've evaluated that, or if you have the same sort of if you applied that the model of hexagonal visualization with those axes, what you might see.
Yeah, we have some. We haven't formally compared that. So we've gone through every major cause of death and done our Hexamaps, and I have to say it's coffee table material, believe it or not. That they would want to put it together into a book, just because it's fascinating to look at these patterns. And then but we have not done a formal comparison of drug. That's a terrific idea. I suspect there are some strong relationships there.
Yeah. No,
they may be inverse relationships, actually. If you look at tobacco and drugs, that's that they would not be necessarily growing together, but maybe higher in the what do they call the silent generation, and moving toward generation Z or whatever letter they have.
But the idea that there are addictive substances and comparing those and seeing if there are temporal shifts by generation is a good idea.
Yeah, that was terrific, and a book would be amazing. It sort of be a real continued articulation of sort of the Edward Tufte visualization of quantitative information idea.
Yeah.
Really terrific. So there's another question. This is from Bruce Pittman. It was about thinking about the connection of coming up with those sort of rules for transitions in an agent-based model versus the fitted models that you have on sort of more integrated information, and how those two sort of communicate with each other, and thinking about sort of also uncertainties and how they translate across those two types of measures, or two types of structures.
Yeah. So I would take the analytic work that we're doing here we're not simulating, we're just fitting. We're fitting and visualizing, and I view this as if we're going to have an agent representation, and we're going to have state transitions and emergent phenomena, we need to be able to calibrate them to these substructures. So first, the easy one's going to be, fitting something to an exponential curve. That shouldn't be too hard. But then the question is, what about all of these substructures, particularly the year-to-year changes, other cohort changes? And I think the answer is that yes, they fit with each other, but our job is to make the agents reproduce these patterns. And these patterns are, these are macro patterns we're talking about. We're talking about hundreds of thousands of people. These are what we want to do is have the agent simulations reproduce those patterns by however the algorithms make them come about.
Sure, sure. No, because we were just sort of curious, how many ways can you set a set of rules that approximate those macro patterns?
Yeah.
So that's and so there was another question in the chat from Liam Widener. He is asking, is there data out there at the moment that you have processed to describe the change and shift of drug use and overdose deaths as related to COVID, potential usage and cultural shifts that change your current projections?
Yeah, no, the answer is, and the problem with all of these data, which I will give you a little bit of a rant here for a moment. And the rant is that that our national data on fatalities isn't certified for more than a year after the end of the data. So that we have provisional data, but even the provisional data is lags by 6 months or so. So how is it that financial markets can tell us the production of molybdenum out of Sierra Leone, in 10 seconds, but we can't count the number of dead people, from drug overdoses for 6 months. That's one of the great things that I think is going to happen with the American Rescue Plan. There's a substantial amount of funding for improving data systems for public health surveillance. They are cumbersome, antiquated, and they're in desperate need of attention. So that's a long-winded way of saying, yeah, sorry, I can't tell you just because I don't have the data yet. There's a fair amount of anecdotal information that says that drug overdose use and deaths are up, but that's not available through the data systems that we use. And here's my suspicion is what's going to happen is that it'll probably be a bump in the curve, a wobble. We'll get an upward wobble during the COVID epidemic, and then there'll be another downward wobble. And that will go back to the exponential curve. But I can't. By the way, it was 4 years ago that we did, first say that this was an exponential growth, and the curve stayed pretty tight on it for 4 years right now, even with one major wobble that was induced by the carfentanil bump, and then it came back again. So I'm getting more confident now that this is a real phenomenon. It's almost as good as Moore's law. And I don't know how long it's going to last.
Oh, it's truly a frightening rate of increase. But
could I just ask one personal, well, not personal question? I'm on the opiate task force for Montgomery County, Maryland. Would I be able to go into Fred and get information specifically for my county?
Not yet. So the stuff that we have online right now is the CDC gave us a number of priority counties, and so that's what's up now. And our hope is that we'll be able to continue this. We would like it so that anybody in any county, particularly any county of significant size, would be able to run Fred for their county. I'm a believer that agent-based simulations for lots of things are going to be useful in the future, not only for COVID and for drug overdoses, but I see that it won't be maybe 5 years or 10 years before people are sitting at terminals and asking what happens if I increase the availability of treatment slots or naloxone or other, and to do that routinely for their counties. That should be happening.
That we have, you're absolutely right, because all I look at every month are more bar charts, bar graphs.
Yeah, I have to say, I've had a couple conversations with my epidemiology friends, and if you look at the journals, the figures could have been drawn in 1920. For the most part, they're bar charts and dashed lines and and I don't and we really need, I'm happy, with our, visualizations. I think that they are easy to look at. They take a little study, they take a little time to figure it out. But but having visualizations, color is more expensive for journals. It's a little harder. But everybody does stuff online now anyway. So, and seeing these things online, is relatively cheap with color. So, we just need to. There's a lot of room for improvement.
So maybe journals will move the way of Jupyter notebooks, so that you can actually go through and have something really interactive. That would really.
Yeah, I think that is going to be happening. Yeah.
Yeah. So there was a question from Joe Kolchik. He asks, do you think novel programs such as the naloxone leave behind program will have a greater impact versus increasing the treatment centers and supply? So I don't know what the naloxone leave behind program is. Sorry, I should have silenced that. So I don't know if are you familiar with the naloxone leave behind program, or should we get a clarification from Joe?
Yeah, I'd like a clarification.
Joe, if you want to, I don't know if you're able to unmute, or if you want to put in the chat what the naloxone leave behind program is. So.
Certainly. So I'm an EMT out here in Amherst, New York. So our new program is to leave behind a single-use naloxone for any overdose that we go to. So it's just one of those new pilot programs. Yeah, instead of just doing the same thing, we're trying something different.
Yeah, it makes good sense. I'd have to, we could run through a simulation on that, to and see what an impact. My guess is that it will have some impact. As I said, even doubling the amount of naloxone that we're distributing now, it's not getting to enough places. So, even, a lot of leave behind, would that work? It might. We'll see.
Thank you.
Are there any other questions? If anyone wants to put things into the chat.
I just wanted to clarify this from CNN that the president's 2020 State of the Union address contained fake news. Is that right?
I didn't say that. What I did say was that it was an overly optimistic, and I have to say it wasn't the president. A lot of people and a lot of professionals shared the same opinion, that things were looking good because the curve was bending down. Yeah. But if you looked at it in a historical context, the curve was bending down because it had just bent up a lot more than it should have. So I didn't mean to single out the president. The entire medical community was also but there's a tendency, as you know, there's a tendency to cherry pick data and make yourself look good.
I guess it really highlights the need to understand the information and separate out effectively subpopulations that may be driving the curves.
Yep.
So it looks like I don't see any further questions. With that, Don, I will thank you very much for taking time to present to the group and for CDSE days, and for all the questions. And this talk was recorded, and it'll be posted probably mid next week and be available. Thank you again.
Well, good. Thanks for the opportunity. Enjoyed it. Take care.
Thank you very much, Don. Bye-bye.